So today we'll be discussing care of HIV-infected adolescents in terms of how to offer HIV services to adolescents who are HIV infected. I think it's a topical issue within our HIV program and within the country, because we have a big number of patients who are adolescents who are HIV infected, and they remain at risk of acquiring HIV infection. They are also at risk of being lost in care. So it's an important aspect in terms of HIV programming. So I'll start by defining the definition of an adolescent. What is an adolescent? According to the World Health Organization, adolescents are individuals in the age group between 10 to 19 years, and the teen years, those are the adolescent years. But you also talk of young people, and you also talk of youth or young adults. So in terms of youth, that's the 15 to 24, and young people, that's the 20 to 24 in terms of the age group. But our focus will be mainly the 10 to 19 age group for this. Then we also talk of children. When I'm talking of children, usually children is less than 15 years, and those are children. So if you see most of the HIV programs, they can say adults and children. Then children is up to 15 years. But if you look in this world, there are all this mixture of these years, 10 to 19, 15 to 24, 10 to 24, depending on what are the issues which you'll be dealing with. So as I said, who defines adolescence as the age between 10 to 19 years? And this is a very critical people in one's life. Why? Because during this period, there are rapid changes in physical, emotional, cognitive, and social issues. So during this period, that's the transition periods where someone transitions from being a child to being an adult. And as part of those transitionals, we don't only expect the physical changes, but we also experience some of the emotional, cognitive, and social changes which happen during this. So as I mentioned, it's a transition between childhood and adulthood. During that process, there are major physical, emotional, cognitive changes, as well as significant changes in the relationship between adolescents, their family. If there was some problem, there also interaction between their caregivers and their peers. Usually, we define adolescents for ease of understanding. If you check in some of the articles on some of the literature, we define the development of adolescents into three. We have got the 11 to 14 age group, 14 to 16, 16 to 19 years. Yes, we have got these ages from 11 to 14, 14 to G, but it's not like really fixed, and there is overlap in terms of developmental issues between these ages. But roughly, in terms of what happens at each of these stages, the first stage, which is the 11 to 14, is mainly to do with the puberty, where their body changes, and because of these body changes, someone might have feeling strange, not recognizing themselves. To those who will be HIV positive, then there's issues of how to disclose their HIV status. So this one is mainly has to do with the puberty. I will not go in detail in terms of the pubertal changes. I believe you understand this. Then the next one is from 14 to 16 years. And during this stage, usually there's this one now tend to realize themselves, and they are remodeling in terms of parental ties. So if someone is HIV or they have a chronic condition, there are issues to do with dealing with death, and during this period, there's high risk of depression, feeling insecure about the future. Imagine someone is HIV positive and they are aware of their condition. So because of that, they can have this insecurity of the future, which might actually also lead to school difficulties. Then issues to do with experimentation, which might also be a challenge. If someone is taking drugs, they might have challenges in adherence problems because of these issues. Then the last stage, 16 to 19, during this stage, more focus is now really try to engage, try to make relationships, and getting a boyfriend or getting a girlfriend. Then, try to really identify themselves and be part of a social system. So if someone is HIV positive, then really there's this feeling of insecure about the future, then the risk of sexual transmission of HIV to those who will be HIV negative. So in summary, these are really the stages which happen there, but you can read more to try to understand some of those issues. So in terms of HIV and adolescents, I didn't manage to, I'll give you maybe some statistics in terms of Zimbabwe, in terms of the number of people and adolescents who are living with HIV. We have had a challenge within our system in terms of estimating the number of people living with HIV, because of the modeling which is done to estimate these numbers. But I think starting from the recent years, we now have accurate numbers. But in most cases, prior to that, the epidemic among the adolescents was almost invisible. It was not like really something which was really seen. But now I think there's more focus now on adolescents, and because of that, we now have statistics. Then in terms of the number of new infections which we get per day between the 15 to 24, remember, we tend to group as I said, we have got that specific age group from 10 to 19, but you can see, usually we tend to talk much about the 15 to 24, which is adolescents and young adults. We group that together. Then below 15, those are children. So in terms of infections, among young adolescents and young adults, you have around 5,000 to 6,000 being infected per day. Then in terms of the statistics, if you look globally, 25% of those living with HIV are under 25. In terms of how the adolescents acquire HIV, we have two main ways through which adolescents acquire HIV. The first one is vertical transmission. So vertical transmission, this is the transmission which occurs mother to child transmission of HIV. When the mother is HIV positive, then the HIV virus moves from the mother to the child. So then we got the vertical transmission. So we have adolescents actually who acquire HIV through the horizontal and the transmission. This one is mainly through the sexual. So in terms of vertical transmission, if you check within our setting for the children who are on ART, around 5 to 10% of those, and they acquire HIV, through the vertical pathway. So in terms of vertical transmission, before I go into, maybe I need to ask a question. Can someone explain or describe how do children acquire, at what stages do children acquire vertical transmission of HIV? At what stages? You can raise your hand and unmute yourself. At what stages do we have vertical transmission of HIV? Yes.
During pregnancy. During delivery and during breastfeeding.
Yes. And so in terms of vertical transmission, as you correctly said, children acquire HIV during pregnancy, during breastfeeding, and during labor. In terms of proportions, I think 60% of the infections, they happen usually during delivery. Why? Because during delivery, now, there's the mixture with blood and all those other issues. Then breastfeeding, the ANC, I think is 15%, breastfeeding is around 25%. So most of the infections, they happen. I hope you had a lecture for PMTCT. I will discuss on how you prevent HIV during those various stages. I believe that was covered during PMTCT. Then in terms of those who acquire HIV vertically, we have got three, in terms of progression, we have three categories. We have what we call rapid progressors. These, they constitute 25%. These ones, most of them, they die, they experience opportunistic infections very early on in life, things like PCP, candidiasis, encephalopathy, and and most of them, usually they don't pass their second birthday. But usually 25, their second birthday, but the majority, they die within the first year. Then we've got intermediate progressors. They form 70% of the patients. Usually they are symptomatic for around 4 to 5 years. Often they present with the constitutional syndromes, your fever, your loss of weight. Then these ones, they start in terms of progression, as I said, after 5 years, that's when they start to be symptomatic. Then we have the slow progressors. These ones, they are symptomatic for almost 8 to 10 years. But because of the HIV infection, they often present with they're not like really growing properly. Even at the school, they've got issues, they've got short stature, or they can have episodic cases of illness. Maybe they are being admitted there. So this one is actually explaining the natural history for those who have vertical transmission without really treatment. But because of treatment now, really we no longer see, and we no longer really see some of these cases. Because now people can be tested for HIV at birth, then they can actually be put on ads there and there. So these days, yes, it's very rare to have an adolescent, being diagnosed for HIV for the first time at 10 years, because also of the way, and because of the knowledge and the awareness which is among our populace these days. Then, in terms of those who acquire HIV horizontally now and through sexual, what are the risk factors for acquiring HIV horizontally, which is sexually? Mainly, as I said, the youthful age between 15 to 24, sex for money, those who do transactional sex, they become at risk. Then the more sexual partners you have, the higher the risk. Those who are ever married, the higher the risk. History of sexually transmitted infection is also really increases the risk. Then the age of sexual debut is also increases the risk. Then we have got multi-generational sex, where you have your sugar daddies, or your sugar mamas, or your Ben 10. So that large age difference also increases the risk of acquiring HIV to adolescents who are who acquire HIV sexually. There's this notion where people really tend to just assume, if they see an adolescent, maybe who is maybe they are 15 or they are 12 years, you tend to assume maybe they acquire HIV from birth. Yes, the majority, they acquire HIV from birth, but don't be blinkered and to just assume all adolescents will get HIV from birth. Some of them actually, they really get HIV and it's from sexual, and it's from sexual encounters. And these are the risk factors which I have mentioned. Then, in terms of the sexual debut, there are studies. I'm not sure in terms of the recent studies and in terms of within our setting, But I think within our setting, our sexual debut can be as low as, as low as maybe 10, 12 years there. We have actually students, with, children actually who are starting actually to have sex at those lower age. But roughly majority of the, of children or girls, they tend to start sex at a higher age, at least 15, 16, something like that. But if you compare the sexual debut for girls and boys, they are different. Where you have got boys start a bit late as compared to girls. For your homework, I want you to go and read around and Google the current sexual debut within the country. I think you can get this from these Zimbabwe demographic health surveys and all those other issues. This graph is just showing the sexual debut in Europe between 1922 and 1973. Actually, just showing it. It's not only in Africa where you have got this decrease in the age of sexual debut. So if you look like long back, it used to be around 20, 23, but now in some of the countries it's below. And I think by now, this was like for some data for 73, but if you look further, actually, I think it is way below 16 years, maybe 10, 10 years because of the changes which are happening. Then in terms of the risk factors, remember we mentioned the issue of sexual debut. Why is it a serious issue for girls? It is a serious issue for girls. Why? Because they've got immature genital tract. And this immature genital tract is more vulnerable to STIs and HIV. So some of the issues now of early sexual debut, they've got insufficient thickness of the vaginal wall. So the risk of actually getting injury or getting bruises becomes very high. They've got insufficient mucus production. Remember, as part of sex, the issue of lubrication, they are very important. So because of that, they also have this challenge, which then increases the chances of having bruises, tight sex, which then predisposes them towards HIV. Then they've got single layer columnar cells. I think if you remember your histology, and these, they are more susceptible to chlamydia and gonococci. Then, so in general, as I said, the physical development, the age of sexual debut, that's where the issues are in terms of really immaturity of the genital organs, which then increases the chances of trauma, then increasing the risk of getting HIV infection. Then if you then come to the issue of having adolescents HIV program, it is very critical to have a conceptual framework for developing comprehensive, effective, and integrated HIV prevention care and programs. Because because of this challenge which you continue to have, we then need to make sure what we are implementing is comprehensive. There's integration because we have this challenge of adolescents having HIV within our setting. What are some of the issues which you need to consider when you are implementing HIV within adolescents? Number one, we need to make sure there's early diagnosis and disclosure. So in terms of early diagnosis, these days, we talk of PMTCT, and we also talk of infant testing and all those other issues, EID. So I think that one is not really an issue, but we have really some others who are missed within the process. But as part of PMTCT, if you check the testing rates for PMTCT among pregnant women, I think it's almost more than 95%. Yes, we've got a few who deliver at home. So all those mothers who will be aware of their HIV status, they also really take the necessary steps to make sure they test their children at the various recommended time points. Then to those who are HIV positive, who are on treatment, some of them, they really start, they are tested very, at a very young age. Maybe they are tested at 1 year, then they are started on treatment. There's this important issue, which is very pertinent in terms of disclosure. When do you disclose? And when do you disclose, someone in terms of their HIV status for adolescents? I will not go in detail in terms of this. Try to explain this disclosure, whatever, in terms of this process of disclosure. But usually we say disclosure is not an event; it has to be a process. Usually we recommend, by around 6, 7, 8 years, to start really disclosing the HIV status of a child. And by 10 years, actually, usually by 10, 12, they should know their status. Why? Because at that stage, they're now starting, dating and all those issues. So at that stage, you need to be sure they are aware of their of their status. Then another important issue is to do with adherence. Because of the challenges which you mentioned from the start, we need to make sure that as adolescents, as we're offering HIV services, we have good systems to support adherence, the issue of counseling and the issue of peer support. Then effects of long-term therapy and the issues to do with resistance. Long back, we used to have side effects like lipodystrophy, but these days, because of the regimens which we are getting, is no longer an issue. Then another important issue is issues of advocate and action to make sure there's political will in trying to address issues to do with adolescents. I think in our setting, we are doing very well. Then we also need the resources to make sure we make the HIV, we make the clinics youth-friendly or adolescent-friendly when we are offering HIV care and treatment services. So in terms of challenges, what are some of the challenges which you experience when you're offering HIV to infect adolescents? One of the challenges is adolescents, as I mentioned, is not a homogeneous group, and you have got, because of the ages, and some of them, they're out of school, some they are parents themselves, some of them they are orphans, some of them they are the heads of the family, some are tested and some are not. So because of that, it becomes very complex really to offer services to adolescents. So because of that, also one size fits all. It doesn't work because they are not the same. Then, as I mentioned, we also have adolescents getting HIV. Others they are getting HIV vertical transmission. Others they are getting HIV from horizontal transmission. And at times, it is very difficult to distinguish between these two. So because of that, it then poses a challenge. Then other challenges which we have, issues to do with social pressure. For those now who will be HIV and who will be HIV positive, most of them, in terms of growing up, and they won't really be growing properly. They end up having short stature, or they've got delayed puberty. Then for them to really cope with their HIV diagnosis is also a challenge, which can then affect their relationships, either intimate relationship or relationships within their family. Then the issues of stigma, actually, they are also a challenge, which then lead to challenges in terms of them being accepted by their family and their society. Other challenges which we have, issues to do with poverty, young children, especially young women, they're at risk of sex trades. I mentioned the issues of sugar daddies, then issues to do with civil unrest. Yes, in our setting, it doesn't apply. But if you go to places now, because of these economic issues now, we have people really migrating, things like Cyclone Idai also really contributing to some of those issues. Then other challenges which we have I mentioned issues of stigma and discrimination, then issues of confidentiality, issues of economic dependence, and if they are not independent, they really need to get support from their parents or from their caregivers. So because of that, it really becomes a challenge to provide care to them. They need bus fare and all those issues to come to the clinic. It then becomes a challenge. Then there's limited access to health information and care. So I think it's also a challenge in terms of access towards access to services. Then we also have barriers to HIV care in terms of some of the things actually which needs to be addressed, which stops adolescents for them to receive care, which includes the majority, they are not aware of their HIV status because they have not been tested. And if you go to most of the clinics, some of the clinics now things have improved, but long back, some of the clinics, they are not comfortable to offer HIV testing services to adolescents because they lack the necessary skills. Then there's also, now things are trying to improve. There is lack of adolescents-focused health services available. Other barriers, as I mentioned, I think there are a lot of them here. You can go through them in the slides alone. With many positive adolescents, they are in denial about their disease. So because of that, they postpone confronting the issue. They delay to be tested. Why? Because of fear of rejection and isolation. Then because of the HIV, at times it affects the brain directly. So I hope you know that the HIV virus is neurotrophic, which means so because of that, you can have impairment in cognitive development. This then might have, affect, in terms of social skills, fear, mistrust of medical system, and many other things. And as usual, we always have financial challenges. Let's say now we are confronted with an adolescent who is in need of care. What are some of the things which you need to really take care of as you offer care to these adolescents? The first thing, we need to make sure we get the history. And from the history, we need to understand things to do, their family, their school, their sexual history, their risk-taking behaviors, things like smoking. Then for examination, we have to do the usual examination we should do. Then for investigation, it's always wiser to check, to check for some of those other conditions, including pregnancy test. And if there are STIs, you treat those STI. So it's in terms of providing care, it is critical to make sure adolescents they've got adequate health education and counseling, and they need to have adequate information regarding HIV transmission, and then in terms of treatment options. Then they need to have adequate information according to sexual health issues of how they manage their sexual feeling, how they prevent STIs and family planning. It is also important to refer them to appropriate counseling services in case they need those services. Then family planning is also very important for HIV-infected adolescents. What are some of the issues which are important in terms of family planning? In terms of family planning, most of the methods actually which we use for family planning, they are safer if they are provided to HIV-infected adolescents. But usually, we always recommend the use of dual methods. Why? Because we want to prevent reinfection. Then in terms of the actual ARV drugs which we give to adolescents, I'm not going to go in detail in terms of the drugs. I hope you've done your courses in HIV. But usually for adolescents, we just need to make sure they get simplified regimens. Why? Because if you give them regimens which are complex, it will be very difficult for them to adhere. So you need to make sure these days, I think things have improved where people are getting once a day regimen. So it's also very important to make sure we do that. Then, yeah, so I think issues to do with side effects. I hope you are aware when we introduced Adherence 400, the priority group actually, it was adolescents and it before adults. Why? Because we know because of their issues. So we had actually to really prioritize adolescents. So in terms of art, one thing which is important for adolescents is to make sure that they are given regimens which they can adhere to. What are some of the factors actually which can contribute to good adherence in adolescents? If they've got adequate support, if there's stability in their life, and if they are familiarity with people responding to therapy, if they know someone who is on art, actually it's a good motivator in terms of adherence. And if they are getting treatments in a manner which is non-judgmental, so it is also really to promote adherence. And if there's change in their health status, you are taking drugs and actually seeing you are getting better. And let's say you used to have rashes, whatever you used to have, but as you take medication, as you see those things disappearing, actually you'd also be kind of really prompted or pushed to take your medication properly. So in terms of treatments, some of the problems where you can have challenges with adolescents in terms of really accepting and getting into therapy. Some of them, they are in denial, and some of them, they've got concrete thinking. Others, issues to do with trust, and issues to do with disorganized lifestyle, issues to do with transportation and funding, and fear of secrecy, and all those issues. They can actually affect the adolescents in terms of taking their drugs. So you can read here some of the reasons. One of the studies which was done where the reasons why they report missing and adherence. Some of the reasons include too many pills, disclosure concern, depression. It reminds them that I'm HIV positive, issues to do with side effects, and actually even forgetting. So these are some of the reasons actually which really cause adolescents not to stick to their treatment. How then do we make sure with adolescents they adhere to their treatments? So these are some of the strategies which you can implement. The first one, which is being to prescribe regimens that fit into the adolescent's life as much as possible. You don't want to give someone a drug regimen which changes their lifestyle. So you need to make sure whatever treatment they are getting, it doesn't really affect as much in terms of their lifestyle. You need to make sure there's a positive approach to treatments that nurtures adolescents believe in their success. Then you need to make sure adolescents, there's advanced preparation in discuss of side effects. They need to know some of the common side effects and they anticipate them so that when these side effects appear, they can actually go to a health facility and their medication is changed and the issues they are discussed. Then full disclosure, I discussed about disclosure to say disclosure is not an event. It is what? It is a process. So we have got full disclosure. As I said, at around 10, 11, 12 years, you should have full disclosure. But before, you have partial disclosure. Then you also have social support, which is very important. Screening for depression is also very important. Yeah. Sorry, my phone is running out of power. My office doesn't have power. So some of the slides, I'll skip them, but I think you can read them in terms of understanding some of the strategies to improve adherence among adolescents. Then some of them, they actually don't like to initiate art. What are some of the reasons why they don't want to initiate art? In terms of actually really putting them on art, and it might be a challenge before we talk of adherence. These are some of the reasons, which include unstable clinical status, lab parameters, unstable living conditions, lack of social support, and many other things there. Then it is also important when we are offering adolescent services, we do it in a multi-disciplinary, where we make sure we have got healthcare workers and we've got doctors, we've got nurses, we've got counselors, so that really they get all the necessary skills and it in offering. Then we've got the concept of adolescent-friendly health services. Now, I'll not go in detail, you can read this alone, but actually what it's saying, we just need to make sure at the clinic, we need to make sure the services which we offer, and in terms of the setting, in terms of the language, in terms of organization and all those things, we need to make sure we've got adolescent-friendly services. If my computer just turn off, that will be the end here. I hope I will have, don't wait for me. It means my batteries will be flattening. I've tried to charge it, but the other office doesn't have internet. So if my computer turns off, that will be the end of the lesson. Then what are some of the things which you need to provide to make sure we have got adolescent-friendly services? As I mentioned, you need to make sure you've got HIV and STD education. We need to talk about risk reduction, issues to do with self-esteem. They're very important. And usually, because of their HIV status, they tend to lose confidence. So because of that, as part of really this adolescent-friendly health services, you need to offer them psychosocial support. Then, in this, within the country, we have our own homegrown model, which is called the Community Adolescents Treatment Supporters, where we have got other adolescents and who offer support, peer support to some of their colleagues. So we call them KETs. I hope some of you have been to attachment or have been to clinics where you have seen these KETs. You can read around these KETs to understand, in terms of what they do. And there are a lot of publications which have been published around the KETs. You can Google or the Jandiri program. Who are these kids? These are other adolescents who are HIV positive between 18 to 24. They are on arts and they are doing well. They are able to read and write. They are out of school. And their main duty is to support other adolescents who are having HIV issues. And they support the caregivers of those adolescents